This is Randy Schell, and this is a podcast on thyroid and parathyroid disorders and anesthesia. It is part of the University of Kentucky College of Medicine Department of Anesthesiology didactic series. Let's first look at the American Board of Anesthesia in-training exam keywords between 2006 and 2017, the most recent in-training exam on the topics thyroid and parathyroid disorders. Under thyroid, you can see preoperative thyroid assessment, hyperthyroidism, hypothyroidism, injury to nerves near the thyroid, and other complications such as injury to the parathyroids resulting in postoperative hypocalcemia. And under parathyroid, you can see hyperparathyroidism, some of the signs of it, hypoparathyroidism, treatment of it, and some postoperative causes such as injury to the parathyroid gland during thyroid surgery, for example, and the antagonism of neuromuscular blockade that occurs when you are hypercalcemic with hyperparathyroidism. Let's talk about the thyroid gland, its anatomy and physiology. And on the left, you can see an anatomic diagram of the thyroid sitting on top of the trachea. You can see that if a thyroid grew very large, for example, was goitrous and pressed on the trachea, tracheomalacia could occur. Also, if you look at the stars on the top left, you can see the superior laryngeal nerve coming down and supplying via its internal branch the sensation above the vocal cords, and the external branch, which supplies the cricothyroid muscle to the vocal cords. Well, the recurrent laryngeal nerve is also near the thyroid, and it supplies sensation below the vocal cords and all the muscles of the vocal cords except the cricothyroid. So injury to either of these nerves during thyroid surgery could result in problems with vocal cord movement postoperatively. On the far right represents the physiology of the thyroid system, starting up at the hypothalamus and the release of thyrotropin-releasing hormone, causing the anterior pituitary gland to release thyroid-stimulating hormone, which then acts on the thyroid to result in the release of thyroid hormones, T3 and T4, which in the periphery results in thyroid hormone effects, including increased metabolism, growth and development, and increased catecholamine effects. The thyroid hormones T3 and T4 are discussed next. The thyroid secretes mainly T4, in fact in a ratio of about 10 to 1. The half-life of T4 is longer than T3. It's in the range of about a week in the circulation. So therefore, a hyperthyroid patient who's secreting a lot of T4, even if you take out the thyroid gland, there still can be a lot of T4 circulating in the body for some period of time afterwards. T3 mediates most of the physiologic effects of the thyroid hormone. 80% of it's produced by taking an iodine molecule off of T4, therefore making T3, but some of the T3 comes from the thyroid itself. T3 is more potent than is T4, and it has a shorter half-life. When thyroid hormone supplements are needed, usually it's intravenous T3 that is given. The cardiovascular effects of thyroid hormone will be shown better graphically in the next slide, but simplistically, it's mainly T3 that has the effect on the cardiovascular system of increasing heart contractility, vasodilating, and resulting eventually in increased intravascular volume. Let's look at the cardiovascular effects of thyroid hormone in more detail. Starting up at the top left, you can see that with hyperthyroidism, and we'll follow hyperthyroidism through this graphically first, there is increased thermogenesis, increased metabolism. There is a decrease in systemic vascular resistance. The first 1500 to 1700 dyne second centimeters to the minus fifth is approximately normal, while some approximate values are given here for hyperthyroidism, that is, lower systemic vascular resistance, lower diastolic blood pressure, And with that lower diastolic blood pressure and activation of the renin-angiotensin system and increased preload. And with hyperthyroidism, cardiac output goes up from the normal approximate 4 to 6 liters per minute to, for example, greater than 7, as represented down here. And with hyperthyroidism, you also get chronotropy, or increased heart rate, and inotropy, or contractility of the heart, and afterload is reduced. Now, if we compare hyperthyroidism to hypothyroidism, when we have a low thyroid hormone, thermogenesis is reduced. Patients are often cold. Systemic vascular resistance goes up. They're vasoconstricted. Diastolic blood pressure goes up. Pulse pressure may be reduced. And afterload goes up. The heart rate goes down. They become bradycardic, and inotropy is reduced such that a very severely hypothyroid patient who you induce general anesthesia on with a drug like propofol, you may uncover that reduced contractility that is present with hypothyroidism, and cardiac output can be decreased. What are some tests for thyroid disease? Well, TSH is the single best test of thyroid action at the cellular level. And in blue, hyper and hypothyroidism and the effect on TSH and T4 and T3 are shown in this graphic. If you have avert hyperthyroidism, you are tachycardic and hypertensive, or you are tachycardic with increased contractility, and you're hot and hypermetabolic, overt hyperthyroidism, your TSH goes down. Why? Because if the thyroid is producing a ton of T4 and T3, it's a problem with the thyroid producing so much. The pituitary is shut down, and the TSH levels go down. So when you measure TSH, it's very low. If you measure T4 and T3, they're greatly increased. Now, if a patient is hypothyroid, very hypothyroid, the thyroid isn't producing T4 and T3, so the brain says, hey, we need more, so they kicks in and produces a bunch of TSH, which becomes very, very high, and that's what we often detect in patients clinically and measure to show that they are actually hypothyroid. So TSH, very sensitive for detecting hypothyroidism. Let's start with hyperthyroidism, the etiology being Graves' disease frequently, or multinodular diffuse goiter, and other causes like a thyroid adenoma that produces thyroid hormone, or thyroiditis such as post-viral disease. Some of the manifestations of hyperthyroidism include that the thyroid may grow in size and become goitrous, and if it becomes very large, it can compress the airway. In patients with airway compression, if you do pulmonary function tests, as represented on the far right, you can see a classic pattern of fixed obstruction. Let's look at that now. Up at the top is meant to represent the goitrous thyroid around the trachea, compressing it. And when a patient breathes in, which is the lower part of this flow volume curve, it is truncated. And when they breathe out, it's truncated. So you get this blunting of both inspiration and expiration. It's called a fixed obstruction, and that's what you would see in a flow volume loop classically. The patient who is hyperthyroid is hypermetabolic. Their heart is just fast and highly contractile, and their cardiac output is high. In fact, they can develop high output cardiac failure and even induce angina because of the tachycardia that occurs and increased oxygen use that the heart is requiring if they have flow limiting coronary artery disease. Heart can get big. Diastolic pressure tends to go down as systolic pressure goes up, and a wide pulse pressure is often present. The patient may lose weight, and skeletal muscle weakness may occur, and the adrenal, which becomes hyperplastic, may result in increased cortisol requirements, and supplementation of glucocorticoids may become important in the perioperative period in these patients because of this. The treatment for hyperthyroidism is make the patient euthyroid if possible before surgery. However, mild hyperthyroidism is not a great risk for surgery if you have time. Making them euthyroid makes sense because the risk of thyroid storm is always present, and that is a patient who has poorly controlled hyperthyroidism, which releases tons of thyroid hormone in the perioperative period and the stress of the surgery, and the consequences of those thyroid hormone results in the thyroid storm, which is characterized by the increased contractility and tachycardia and hypermetabolism and hyperthermia. So how can we treat hyperthyroidism? The first line of therapy is antithyroid drugs such as metimazole and propylthiouracil. These drugs actually inhibit the synthesis of thyroid hormone, but it takes weeks to get someone into a euthyroid state using these drugs. Iodine can be used also. It inhibits the release of thyroid hormone and can make the thyroid smaller and easier to operate on. But an important point is don't give iodine before the antithyroid drugs, because if you give iodide first, it can actually increase the thyroid hormone stores and exacerbate the thyrotoxic state. So the antithyroid drug first, iodine second, and beta blockers such as propranolol can be used to decrease the adrenergic activity associated with hyperthyroidism, such as the anxiety, the tachycardia, and the tremors that occur. And propranolol is somewhat unique in that it also not only blocks the adrenergic activity, but also decreases the peripheral conversion of T4 to T3. And you remember that T3 is the major potent thyroid hormone having its effect on the cardiovascular system. Hyperthyroidism anesthetic management preoperatively, we want to establish that euthyroid state with drugs like the antithyroid drugs and iodine, for example, and beta blockers, but this is going to take a while. If someone's on those antithyroid drugs preoperatively, we tend to continue those and avoid drugs such as anticholinergics that can make the patient tachycardic. Look at their airway well before surgery and make sure that they don't have laryngeal compression or maybe deviation of the trachea that could make intubation difficult, or they may have a pre-existing laryngeal nerve involvement from thyroid compressing the nerve, for example. You would want to know that before surgery, that it was present and it wasn't caused by surgery itself. Now, if you have a patient with hyperthyroidism who needs to have an emergent surgery, you can block the adrenergic effects of the thyroid hormone with IV beta blockers like esmolol. You can use iodinated contrast and glucocorticoids, which decrease the hormone release and reduce the peripheral conversion of T4 to T3. Remember, Indrall or propranolol also did that. And then propylthiouracil can be given via an NG tube, assuming that it's not the gut that you're working on and maybe it's obstructed. That would not probably be wise to be putting PTU down that type of patient. Be prepared in that emergency surgery to manage thyroid storm with cooling measures and beta blockers and things like that. Intraoperatively, again, airway management, look at their thyroid and look at their midline position of the trachea and make sure they don't have a mediastinal mass that could press on the trachea, carina, and bronchi. After the patient goes off to surgery and positive pressure ventilation is assumed, they may totally obstruct with an anterior mediastinal mass. Hyperthyroidism and hypothyroidism don't change MAC per se unless temperature is changed. If a patient has hyperthyroidism and is not hyperthermic, their temperature is not high, there's no change in MAC. Same thing with hypothyroidism. If they're hypothyroid and not cold, there is no change in MAC. We don't want to have that hyperthyroid patient have a sympathetic nervous system response if at all possible. So we want to make sure they're adequately anesthetized before intubation, avoid drugs that stimulate the sympathetic nervous system such as ketamine and pancuronium and ephedrine and epinephrine. If we need to raise the blood pressure, phenylephrine is a good choice. We can use inhaled anesthetics, nitrous and opioids are all okay. They may have some coexisting muscle disease if they've had long-standing hyperthyroidism, and there's some evidence that they might have reduced requirement to non-depolarizing neuromuscular blocking agents. Regional anesthesia is safe, and you could actually do a superficial cervical plexus block in a hyperthyroid patient for thyroid surgery. Postoperatively, remember that T4 has a half-life of about a week, and you may need to continue beta blocker administration into the postoperative period even after the thyroid is out, and monitor for complications such as thyroid storm, which can present oftentimes about 6 to 18 hours postoperatively. In the first day after thyroid surgery for hyperthyroidism, you're still at risk for thyroid storm. Now, some complications of thyroidectomy. Nerve damage, parathyroid injury, and neck hematoma are the ones to be discussed here. Let's look at nerve damage first. Remember that the superior laryngeal nerve supplies the cricothyroid muscle via the external branch of that superior laryngeal nerve, and it's a tensor of the vocal cords, the cricothyroid. If the superior laryngeal nerve is damaged, the patient tends to have a weak voice, decreased pitch, and it's been classically called a whispery voice after injury to the SLN, superior laryngeal nerve. The recurrent laryngeal nerve, if it is damaged, remember that nerve supplies all the muscles of the vocal cords, and you can have loss of abduction with intact adduction. That is, they're in a midline position, in a paramedian position with possible airway obstruction, and it's really bad if they are just injured bilaterally rather than transected bilaterally. If they're transected bilaterally, they will sit flapping in a paramedian position usually, but if they're injured bilaterally, they may be adducted together and totally obstruct the airway at the end of an operation and may require a tracheostomy. Now, one of the things that is unique to thyroid surgery is monitoring of EMG activity. Some ENT surgeons, especially when the thyroid is large and it may be difficult to locate the recurrent laryngeal nerve, they may use a tube such as the NIMS tube that can be placed through the vocal cords, and with a metal area that is positioned right at the bottom right here between the vocal cords. And obviously neuromuscular blocking agents cannot be used because you're monitoring for, when you get near the recurrent laryngeal nerve and stimulate it, the vocal cords would move around that tube and make contact with the tube, and you want it to be a large tube. You can't put viscous lidocaine or spray up the airway or topicalize the airway. You will block this effect. But if they get near the nerve during thyroidectomy, the vocal cords will close around that, make contact, and an alarm goes off. So succinylcholine, if a neuromuscular blocking agent is needed, is often used rather than rocuronium or vecuronium or pancuronium for intubation. Use a large tube to ensure contact, and as mentioned, don't use local anesthetic on the tube, such as lidocaine, or on the vocal cords. Another problem with thyroidectomy is injury to the parathyroids. Those little rice-sized glands that sit behind the thyroid, if they are inadvertently removed, all of them, you can get acute hypocalcemia, often presenting in the first 24 to 48 hours, and it presents with things like tingling of the lips and fingertips, hypocalcemia with QT prolongation on the electrocardiogram, but usually the patient will complain of, ooh, my lips are tingling, my fingertips are tingling, and if you blow up a blood pressure cuff on their arm, their hand spasms, and if you tap on the side of their forehead, you can get spasm of the orbicularis oculi or Schaffsteck's and Trousseau's sign. The treatment is intravenous calcium, and laryngeal stridor and spasm may require CPAP or intubation. Another complication of thyroidectomy is neck hematoma, expanding, sometimes in the recovery room, requiring opening the incision in an awake patient and letting the hematoma resolve such that the trachea can come back midline. And be very careful about giving induction agents and neuromuscular blocking agents to a patient such as this, because it may be an impossible airway and you take away that patient's ability to breathe on their own. Just think, remove the neck hematoma by opening the incision and letting the clot come out and get the ENT surgeon there emergently. Thyroid storm is a life-threatening exacerbation of hyperthyroidism. It can be precipitated by surgery or infections or stress or withdrawal of iodine therapy. It often occurs in the first day, even in the first 6 to 18 hours postoperatively. But actually you can have thyroid storm occur during thyroid surgery itself, and it presents with the patient getting hot and tachycardic and a high cardiac output, diastolic hypotension. If they were awake, they'd have altered mental status. They can have heart failure and dehydration and hyperglycemia. Shock and death can ensue in patients with thyroid storm. There's lots of other things that can look like thyroid storm: sepsis and pheochromocytoma and cocaine amphetamine intoxication and neuroleptic malignant syndrome, which is associated with antipsychotic dopamine blocking medications, and even MH. So if you were in the intraoperative period and had hyperthermia and tachycardia, you would think, is this MH? And could it be MH versus thyroid storm? And MH and thyroid storm share some characteristics of presentation, such as tachycardia and the hyperthermia and increased oxygen consumption. But MH is going to have also muscle rigidity and increased end tidal and arterial carbon dioxide. So use the CO2 rise and the muscle rigidity to help you differentiate MH from thyroid storm. The treatment for thyroid storm is correct whatever's precipitating it if possible. Beta blockers can block the adrenergic response, slowing the heart rate. IV esmolol is a good choice. Fluids, especially fluids containing glucose. Cooling measures such as Tylenol, and if the patient was, for example, in the operating room, packing him in ice potentially. Antithyroid drugs like propylthiouracil can be given via the nasogastric tube. Steroid replacement is wise because remember that adrenal over a long period of time may be producing lots of steroids, and the patient's used to having high steroid levels, and replacement is wise. And at least 1 hour after you give the PTU, remember, don't give iodine before the antithyroid drugs. Give the antithyroid drug first and then the iodine. Phenylephrine can be given as a direct vasopressor. And usually you can get the thyroid hormone levels back down to normal within 1 to 2 days, but the mortality of this is high, and therefore preventing it is important. Let's move on from hyperthyroidism to hypothyroidism now, or low thyroid hormone. Usually it's the thyroid that's the problem in and of itself, and the thyroid's just not producing enough T4 or T3 despite an increased TSH. The brain kicks in and pituitary and produces lots of TSH, trying to beat the thyroid into producing more thyroid hormone. The etiology of hypothyroidism can be surgery, removal of the thyroid, radioactive iodine ablation therapy for thyroid cancer, for example, and idiopathic and autoimmune. On the far right shows a patient with long-standing hypothyroidism or pituitary myxedema. And you can see all of the changes, including the hair, lethargy, and edema, and changes in the voice, and the patient being cold and not perspiring, and the heart can be affected. Remember that thyroid hormone has a lot of cardiovascular effects, and muscle weakness and reflexes that are prolonged in recoveries. Many of those things can be present in that patient, but nowadays rarely do we see a patient that remains hypothyroid for a long enough period of time to get these changes. Overt hypothyroidism affects the cardiovascular system. Low thyroid hormone and the cardiac output's down, the stroke volume down, the patient's bradycardic, they're not contracting as well. Baroreceptor function can be impaired, and a infusion or effusion, that is, a fluid, can develop around the heart in the pericardial sac, and their systemic vascular resistance can be high. So you can see that if the heart's not functioning well and the vascular resistance is high and there's a pericardial effusion, if you blasted this patient with propofol, you may have a cardiac arrest in a myxedemic hypothyroid patient. Kidney also is messed up by hypothyroidism, and impaired free water excretion occurs, and with more free water around, dilutes the sodium, and hyponatremia can be present. And the respiratory system also is affected in that the ventilatory response to hypoxia and hypercarbia is decreased. That is, normally if you become hypoxic, you should hyperventilate. If you become hypercarbic, you should also hyperventilate, and that is blunted by hypothyroidism. Anesthetic management of hypothyroidism, well, if the patient's mild or asymptomatic, let's say it's picked up by an elevated TSH in the pre-op laboratories or in a primary care physician's office before surgery, this does not appear to significantly increase anesthetic risk. So mild hypothyroidism coming for surgery, most people will not take the time to try to replace them and get the TSH back down into the normal range. Some anesthetic considerations of hypothyroidism: one, the airway can be affected. The thyroid may grow, it may become goitrous, it may compress the trachea. There may be decreased gastric emptying, which could put the patient at risk for reflux and aspiration. Cardiovascular system, because there's not much thyroid hormone around, is hypodynamic with low cardiac output, low stroke volume, bradycardic, and you may need to treat hypotension with drugs that have beta effects and not just pure alpha agonists like phenylephrine, because their heart's just not functioning very well. And if you vasoconstrict that patient and make that heart contract against that higher resistance, it may not do well. Milrinone may be needed to treat decreased contractility, because it doesn't depend on the beta receptors, and those beta receptors' number and sensitivity may be decreased by long-standing hypothyroidism and low thyroid hormone. We said that the thyroid hormone affected the ventilatory response to hypoxia and hypercarbia, and we need to be aware of that in the perioperative setting, and that there will be increased sensitivity to anesthetics like opioids and our IV anesthetics. And if we give, as mentioned before, propofol in high doses to someone with myocardial depression, or turn up our inhaled anesthetic to multiple MAC levels, we may have problems with hypotension, low cardiac output, for example. But remember that hypothyroidism without changes in body temperature doesn't change MAC. Other risks in the perioperative period of being cold and hyponatremic because of that free water management issues in the kidney, and hypoglycemia. Replacing thyroid hormone for emergent surgery. If someone has severe hypothyroidism and you want to replace it, intravenous T3 is effective within about 6 hours and will often replace steroids also, using hydrocortisone or dexamethasone coverage, because of the decreased adrenal cortical function that often accompanies hypothyroidism. But remember that if you have a patient who has coronary artery disease, for example, and you give them T3, which ramps up their cardiac function and their oxygen use by their heart goes up, you may actually precipitate myocardial ischemia when you initiate thyroid replacement. So beware of that. IV T3 is the drug that is chosen in the severe hypothyroid patient for emergent surgery with steroids, but being aware that the cardiovascular effects may uncover a coronary artery disease. Myxedemic coma, the really bad, rare, severe form of hypothyroidism. It's a medical emergency with a very high mortality. Patient presents in coma, not breathing much. They're very cold is the cardinal feature, with impaired thermal regulation. They're bradycardic and hypotensive, and they may have a very low sodium. In that patient, you need to jump right on and give intravenous T3, steroids, and stabilize their vital signs, and possibly mechanically ventilate and warm the patients. Let's move on from the thyroid now to the parathyroid. There's those little glands sitting on the back side of the thyroid gland that can be damaged during thyroid surgery, for example. Parathyroid hormone release is controlled mainly by ionized calcium levels. Now, acutely low magnesium will stimulate the release of parathyroid hormone also, but it's mainly ionized calcium that affects parathyroid hormone release. And so if we look at the far right, you can see those parathyroid glands embedded in the back of the thyroid, and then below, if you look at the effects of the parathyroid glands, the release of parathyroid hormone results in calcium reabsorption and vitamin D hydroxylation and calcium absorption from the intestine and calcium reabsorption from the bones, because what you want when your ionized calcium goes low and your parathyroid hormone ramps up, you want to raise the body's ionized calcium levels, and parathyroid hormone release will work in that direction. Now, calcium can exist in several forms. It can be bound to protein, about half of it is, and the ionized or active form is the one that affects parathyroid hormone release. Now, when you hyperventilate someone and cause a respiratory alkalosis, you can actually decrease ionized calcium. Acidosis does just the reverse. It increases it. So if someone was hypocalcemic and you hyperventilated them, that would not be a very wise thing to do, as it would lower calcium levels even more. Let's talk about hyperparathyroidism first, and a benign adenoma is the cause in many situations. In fact, about 90% of them. Here's an example of a large parathyroid gland. It's a benign adenoma secreting parathyroid hormone, causing hypercalcemia. And up at the top right shows that adenoma secreting parathyroid hormone, which affects calcium reabsorption in the kidney, resorption from the bone, increased calcium uptake by the intestine, and overall resulting in elevations of calcium and lowering of phosphate levels. And these patients that are hypercalcemic can be very weak, they can be depressed, and have the classic bones, groans, moans, and all those kind of things that you learned in medical school, myalgias, nausea, vomiting, kidney stones, cognitive impairment. One of the kind of classic ones that we think about is the effect on the electrocardiogram of hypercalcemia, of shortening the QT interval, and hypercalcemia can enhance cardiac function. How do we treat hypercalcemia? Now, up at the top right shows the electrocardiogram in a patient with hypercalcemia, shortening the QT interval. What you do is initial medical management with lots of saline and Lasix, and let that calcium be excreted through the kidney. That is assuming that they have good kidney function. So saline diuresis, saline dilutes it, and then Lasix inhibits sodium and calcium reabsorption. Remember that thiazide diuretics would not be a great choice, because they can actually enhance renal tubular reabsorption of calcium and cause hypercalcemia in and of themselves. So saline and Lasix in that patient who's hypercalcemic. One of the causes of hypercalcemia is metastatic tumors, and a patient with metastatic tumors who's hypercalcemic, saline, Lasix can lower that calcium level. Other treatment, bisphosphonates, IV disodium etidronate and pamidronate, which inhibit the osteoclast. So we dilute the calcium with saline, we get rid of it from the kidneys and out in the urine with Lasix, and then we can stop the osteoclast from releasing it from bone with bisphosphonates. And if the patient's really bad, you can take them for hemodialysis. You can also give calcitonin, which has a relatively rapid onset of activity with direct inhibition of the osteoclast. And then if unresponsive to these other drugs, mithromycin is another drug that can be given, which I've only given one time in my life to a severely hypercalcemic patient. Also remember to correct the hypophosphatemia that occurs often with hyperparathyroidism. Hypophosphatemia increases the GI absorption of calcium and stimulates the breakdown of bone and impairs the uptake of calcium by bone, impairs cardiac contractility, causes skeletal muscle weakness. So remember, as you're treating the hypercalcemia, measure the phosphate level and correct the hypophosphatemia that may be concomitant. In a patient with hyperparathyroidism in the perioperative period, there's no specific drug or technique that has an advantage over another, but just remember to keep hydrating that patient and keep their urine output up to help them get rid of the calcium. Be careful about positioning the patient, as some of them have osteoporosis and can have fractures that can occur. If their calcium level is very high, the hypercalcemia can antagonize neuromuscular blocking agents. Remember that calcium is associated with presynaptic release of acetylcholine, and lots of calcium around can result in more presynaptic release of acetylcholine, which antagonizes, for example, rocuronium neuromuscular blockade. So a patient with hyperparathyroidism and hypercalcemia may require higher doses of neuromuscular blocking agent. The QT interval, which we've talked about being decreased in the patient with a high calcium level, shortened QT interval, may not be a reliable index of changes in serum calcium, so you need to measure ionized calcium levels as you treat the patient, for example, with Lasix diuresis. Let's switch now to hypoparathyroidism, where the parathyroid is not producing enough parathormone, and the patient's going to be hypocalcemic in this case. And at the top right is an electrocardiogram attempting to show a prolonged QT interval, which is something that we think about with hypocalcemia. So the cardiovascular manifestations of hypocalcemia: the heart may not function as well, the patient can be hypotensive, beta blockers may not work as well. Remember, the end mechanism of most of our inotropic drugs is raising intracellular calcium. So calcium is involved in cardiac contractility. Hypotensive patients reduce contractility in that hypocalcemic patient with a long QT interval, greater than like 0.44, 0.45 for males and females. Now, how can this hypocalcemia occur? It's often post-thyroidectomy, where a patient has had thyroid surgery and possibly damage to the parathyroid glands occurred and maybe not recognized. Signs and symptoms of hypocalcemia after thyroid surgery usually occur within 1 to 2 days postoperatively. It doesn't usually occur immediately postoperatively. So if you have a laryngospasm, for example, immediately postoperatively, that's probably just light anesthesia, extubation during stage 2 anesthesia, for example, rather than hypocalcemic cause of laryngospasm due to hypoparathyroidism. That usually is going to occur 1 to 2 days afterwards. The treatment for the post-thyroidectomy, for example, hypocalcemia, is IV calcium, 1 gram IV initially. Remember, calcium chloride and calcium gluconate can be given, but elemental calcium is present in about 3 times as much in calcium chloride as it is in calcium gluconate. Anesthetic management of a patient with hypocalcemia: try to get the symptoms of hypocalcemia under control before you take a patient to surgery. Replace their calcium with intravenous calcium if it's severe and symptomatic hypocalcemia is present. Remember to treat hypomagnesemia if it's present, because hypocalcemia may be caused by magnesium depletion. So it may not be a parathyroid problem, for example. It may be magnesium depletion. Incorrect serum phosphate excesses if they're present, for example, with aluminum hydroxide phosphate binding resins. So anytime we're talking about calcium and magnesium and phosphate issues, remember that each of them impact the other, and we should be measuring each of those in those situations. Avoid iatrogenic hyperventilation. As mentioned, if you hyperventilate a patient, cause respiratory alkalosis, alkalosis decreases ionized calcium. And so if their calcium's already low and you hyperventilate them, you're going to make it lower and cause more problems. This ends our discussion of thyroid and parathyroid problems. Again, coming back to the key words from the last 10 or more years on the American Board of Anesthesia on this topic, you can see that preoperative thyroid assessment, looking at the airway, looking at TSH levels, thyrotoxicosis, the patient who is hyperthermic and tachycardic with increased contractility and reduced diastolic blood pressure, myxedemic coma, the hypothyroid patient who is bradycardic and hypothermic, cold, and reduced cardiac contractility, and some of the complications of thyroid surgery, such as damaging the recurrent laryngeal nerve. Remember, that supplies all the nerves to the vocal cords except the cricothyroid, which is supplied by the external branch of the superior laryngeal nerve, which also can be injured during surgery, but less problems than with injury to the recurrent laryngeal nerve. Hypocalcemia can occur post-thyroidectomy if you damage the parathyroids, and can present with tingling in the hands and around the lips and spasm of the hands when the blood pressure cuff goes up. Trousseau's and Schell's sign, for example, in that hypocalcemic patient, but usually 24 to 48 hours after surgery. And flow volume loops, if a patient has a goiter, the goiter can compress the trachea and can cause both a decrease in inspiratory flow rates and a decrease in expiratory flow rates. The parathyroid, if you have hyperparathyroidism, the signs are going to be that of hypercalcemia. One of those might be electrocardiographic sign would be shortening of the QT interval. Acute treatment of hypercalcemia, get it down with giving saline along with Lasix and let them get rid of it through their kidney. If a patient's hypoparathyroid, you can replace calcium. One of the causes of postoperative hypocalcemia is post-thyroid surgery where the parathyroid's been damaged. 24 to 48 hours later, the tetany and the tingling around the fingers and the lips, as we talked about previously. Lastly, neuromuscular blockade in hyperparathyroidism. If your calcium is up, you can have antagonism of neuromuscular blockade and require more neuromuscular blocking agent to have the same effect. This ends our discussion of thyroid and parathyroid disorders, and I hope that you have a great day. This is Big Sky, Montana, where I skied recently here with my son and my wife. Have a good one.